All right, I guess we are live. Good afternoon, everyone. My name is Ahmad Barami. I'm the division manager here at Behavioral Health, as well as our equity services manager. We have a special live stream interview we're doing today, a one-on-one with I would say a colleague, a fellow professional, but I wouldn't say, well, she's done more stuff than me. So colleague, but she's on like the next tier of where I'm trying to get to. And I'll introduce her in a second. And we also have our diversity services coordinator, Dennis Horn, on here. Today, we're going to be speaking with Dr. Ebony Williams. Dr. Williams is a trainer, professor, researcher. I'm going to have her share a little bit more about herself with us in a minute. And we're going to be discussing a little bit around the work that she's going to be doing with us here in Fresno County. We're going to discuss a little bit about the specific needs of our LGBTQ communities and really diving into some of the needs based on the intersectionalities within our LGBTQ communities and understanding that our LGBTQ communities are also come from different backgrounds. So they may be Black, Indigenous persons of color, they may be a veteran, they may have been a foster youth, justice involved. So there's a lot of facets to that. We're going to be, I'll be turning off my camera in a little bit. And so this is going to continue to be live stream on YouTube and Facebook, but think of it more like a podcast. And I know it's during noontime. So a lot of people may be listening to it on their phone while they're on a walk, eating lunch, things like that. So you're not going to, we don't have graphics or, a presentation that you'll be missing. So as long as you're able to have the audio, you should be able to listen to the conversation discussion. And then also if you have questions, you do not have to wait to the end. If you've got a specific question to something we're discussing, Dr. Williams is touching on, or want her to maybe clarify, utilizing the chats on either YouTube or Facebook, go ahead and put your question in there. Dennis will then get that question to us, and so we can answer it there. If you have more general questions or things that are not very specific to what we're speaking in that moment, we'll also have a question and answer period towards the end. So we'll go for about 40 minutes or so. And then as questions and comments come in, we'll also try to address those throughout, as well as an opportunity for a straight QA at the end. I'm trying to think, is there anything I missed, Dennis?
I think you've got it all covered.
All right. Well, I am now very happy to introduce Dr. Ebony Williams, who her and I have had a chance to work together several times in the past in different counties and different trainings. And so we're really excited to have her not only on here today for conversation, but that we're going to be collaborating with her to do some work here in Fresno County, which we'll get into in a little bit. With that said, Dr. Williams, welcome. And could you share with the folks a little bit about some of your professional experience, some of your work as a trainer, instructor, just so they get a better sense for who you are?
Yes. Hey, hello, everyone. Thank you for having me, Ahmad, Dennis, and Brian. I'm happy to be here. Just a little bit about my professional experience. I have my doctorate in psychology, so I have my PsyD from John F. Kennedy University. And my clinical experience ranges from various communities of color, individuals of low socioeconomic status. I work with individuals who are considered at risk. I've worked extensively with our LGBTQ plus communities. I've worked with individuals of all various age ranges. I've also worked for the Department of Corrections, where I was a psychologist for individuals who were considered high-risk male youth offenders, ages 15 to 24 years of age. I've also had experience working with high-risk sex offender parolees in my time. I've also worked internationally as a psychologist in New Zealand, where I provided clinical services for individuals of a 21-bed inpatient unit. The populations were NZ Maori and NZ European male individuals who were duly diagnosed, meaning they had either clinical diagnosis coupled with a substance use disorder. And I'm sure that we'll get into that experience as we continue to speak. That's some of my clinical experience. I've worked with a wide range of individuals, various cultural identifications, multicultural identifications, intersectionality. And at this moment, currently I am an assistant professor, tenure track at California State University, Sacramento. And I am the assistant professor for our Marriage, Couples, and Family Counseling Program, MCFC program. It's a graduate counseling program at Sac State. And I also have my own nonprofit organization. It's called Advanced Integrative Services, where I provide technical assistance for various agencies and counties throughout the state of California, focused on social justice, cultural responsiveness, cultural competence, national class standards. And and let me go back really quickly for my work at Sac State. I am a part of the Diversity and Inclusive Excellence Committee, where we are at this point working on anti-racist frameworks within the university to provide more equitable and more inclusive curricula for our students and our graduate students. And I have recently written, or actually co-authored, an article in one of our journals, and it is called Eliminating Counselors' Transphobia, Moving Counseling Forward with Transgender People. I was first author on that. I also have another article that's coming out. It's actually in press at this point. It's called Our Opportunity to Narrow the Gap, Working with Individuals in the LGBTQ Communities. And also, there's a book chapter that I'm a part of that'll be coming out soon. And it's titled Intersectionality, How It Looks. So that's a little bit about me and what I've done in my past and what I'm currently doing right now.
Awesome, and I love that your more recent work, Dr. Williams, in terms of some of the articles, the publication, those things are around intersectionality, because that's definitely, I think, one of the things we want to make sure we highlight and touch on a little more today as part of this conversation. And that's part of some of the work that you're going to be doing with us. So for our listeners out there, the audience out there, Fresno is working with Dr. Williams to create a training for frontline staff, so clinicians, case managers, peer support, folks that are directly working with a person served within our system of care who identify as LGBTQ, and more specifically that have those intersectionalities. And so LGBTQ persons who are also Black, Indigenous, or persons of color. As we had looked around, a lot of times that when we find trainings that are meant to support our competence and hopefully improve our understanding of how to be responsive to our LGBTQ communities, it tends to only look at the individual as a member of the LGBTQ community, and they often don't factor in some of those intersectionalities that Dr. Williams is her work has been focused on. And so not only did we feel that we needed trainings that would also be inclusive, so it factors in those intersectionalities. A lot of times the curriculum and the trainings that are developed in areas outside of Fresno, the Central Valley. And so it doesn't really address some of the gaps and some of the limitations we may have. And so one of the things that Dr. Williams is doing, in addition to developing that training curriculum for us that she will then render, she's also working with us to try to make sure that is a Fresno-centric training that would actually really be applicable to us and our Black, Indigenous, and persons of color in our LGBTQ communities. And so she definitely, I think, from what she shared, has the experience and able to do that. So Dr. Williams, in addition to the academic work, you touched on it earlier as far as some of the work you had done internationally, some of the work you had done with justice populations. And just for clarification, a lot of that work was in what we would broadly call the behavioral health mental health setting, correct? As far as doing counseling and supporting those people through some of the challenges that had probably landed them in those justice systems.
Absolutely. My experience have been that many of my clients were in some of the situations that they were in because of lack of resources. maybe not being able to detect what was going on for them at an earlier stage, so their prognosis would have been a lot better. Lack of access, lack of resources, maybe a depleted support system. And how could we kind of replicate support, empathy, openness, and safety in spaces where may have been historically seen as institutionalized. And this speaks more to health equity, right? The social justice aspects of health, meaning that individuals have a right to living their best life, feeling their most healthy as they possibly can, and have the greatest sense of well-being that they can possibly attain. So an example of trying to incorporate health equity, social justice, and cultural responsive services. I'll give you an example of when I worked in New Zealand, and in my initial stages of working in New Zealand, the agency or the milieu was quite institutionalized. There were no aspects of trauma-informed care integrated in any aspects of the treatment facility. A lot of fluorescent lights, cinder block walls, long institutional keys, steel doors, slam shut. There wasn't a lot of nurturing or aspects of safety that were involved. So myself and our multidisciplinary team thought about ways in which to make the space more inviting, more culturally responsive for the individuals who were clients there. And many of those clients were either heavily medicated, sedated, or despondent. They didn't necessarily interact with their families. And that particular unit in which I worked was not set up for patients or individuals to not be in contact with their families. This wasn't a lockdown facility by any means. So what we decided was to incorporate Maori culture into the environment. So we brought in the kata matuas, the elders of the community. We talked to them about best practices, which centered around Maori culture. We brought in karakia, which is prayer, waiata, which is song. We brought in various artwork and cultural representations of the Maori people. And within weeks, the clients who were sedated or who were isolated in their rooms or who did not want to come out and interact, they began to come out into the day room. They began to participate in their cultural connections. Individuals began to respond because we asked them if they wanted to see their family, and they wanted to see their family, and it became more of an engaging, interactive approach, while also incorporating what we would consider more of the westernized behavioral treatment aspects into their services. And after several months, you would see individuals maybe going to the store with their social worker, or reuniting with their families on weekends, or participating and playing the instruments and singing songs, and taking on a sense of pride within the unit. I would hope that they continue, on that journey and in that direction, because we continue to have the elders present on a daily basis, or if not more days than not, within the facility. We had days for the families to come in. So it was a transformation of sorts there was something quite remarkable. And I think that speaks to cultural responsiveness. I think that speaks to social justice, the health equity, the right to seek, the best well-being, or the services that should be rendered to not only a certain group, should be rendered to all. And that's what we incorporated when I was out there.
Very nice.
Yeah.
And so you said a few things that I jotted down some notes here, but two that I want to kind of maybe combine into a question for you. You talked about cultural connectedness and really the social justice side of health. And so I guess my question is, have you seen good examples or without, and I don't know if this will be something that you'll later on address in the training you're developing, but like how would we do things in terms of ensuring that cultural connectedness and or focusing on that social justice aspect of care when we're looking at then our LGBTQ communities who do come from, communities of colors or other marginalized groups. I mean, have you seen some good practices in there, or I mean, is that something that we as systems of care are still working on trying to improve and really come up with a good idea?
Systems of care, we still have in my opinion, quite a long way to go in making sure that we're providing these resources and access. I do want to give you a shout out though. In my research, I did find that the County of Fresno has created a culturally responsive plan delivered with humility, and you're one of the ones on here that put in a lot of work in making sure that those plans were going to effect. And one of the aspects of that plan is focused on our members of our LGBTQ plus community, veterans, children, older adults, individuals who are considered marginalized. And in order for social justice to prevail, we have to take the time within our various powers and privileges to do our research and figure out which groups or which demographics may not have access to resources, or why they aren't accessible, or what is their perspective on behavioral health or mental health. Those of us who are in these positions, such as you and myself, taking the time to go out into the community to ask and to make sure that individuals are being provided access to resources. Because now, if we're talking about access to resources and we individualize those access to resources, now we're talking about health equity, right? Yep. Making sure that individuals are able to access what they need, because that's their human right. And unfortunately, if we're talking about individuals of the LGBTQ plus communities, historically, they have not been cared for. There have been lack of resources. There have been lack of training within our professional groups around how to interact and understand the LGBTQ plus history, the daily life of individuals who are LGBTQ, and at the same time, not pathologizing the individual sexual orientation or gender identification or gender expression while providing services, is to understand society's impact on these individuals because of the lack of resources, the lack of protective laws, the lack of housing laws, the lack of acceptance around individuals who may not identify with the traditional gender binary, and how that affects employment and raising or trying to create families and support systems. All of those pieces directly impact the individual, their physical health, their mental health, how they feel about themselves, how they want to proceed in life, different journeys that they want to take. And as professionals, we have to be able to contextualize society's impact on the individual and not focus necessarily on the sexual orientation or gender identification or expression. It's really about what the client is coming in to talk to you about or to figure out. And as you're assessing and you're learning more and more about the individual and their various layers of identification, now we're moving into intersectionality and how all of those particular layers have impacted this individual based on society's shortcomings around understanding individuals who may not fit into society's what society considers mainstream or dominant culture.
No, I'm agreeing. The camera's on, so people can't see my head was nodding in agreement with you on that. And so you said a word that you had shared with me a couple of weeks ago. We were talking, and for me, it was kind of like, not that I'm not aware, but it really spoke to me in an aha type of moment of yes, that's the area. And I think you just touched on it a little bit ago as far as understanding what the individual's particular needs are and what are the different layers to their identities. And so I was wondering if we can have you, because you that being in response to saying, not pathologizing the person that they're serving. So everyone was wondering if you could just expand or clarify for that for people that may not really be familiar with the term or understanding it. So maybe more like a layperson's term of like how, or an example of how maybe a therapist might be pathologizing a client of theirs without even being aware of it. So just for the people that are maybe not in the field yet are listening, and they can kind of get a understanding for that part.
Right. Well, an example would be, or could be, a client who comes in and they're saying, speaking about feeling depressed, not necessarily, wanting to interact with individuals, isolating.
Mm-hmm.
And upon assessment, let's say the clinician, upon assessment, they understand that the individual's identification is lesbian. And instead of the clinician continuing to provide space for the client to continue to tell their story about feelings of depression, loneliness, they immediately begin to hone in on the sexual orientation identification of being a lesbian. So they may ask questions around the individual being lesbian. Now, let's be clear. There may be times in which you would ask questions about what it is like for the individual to be in the space within their identification. But I'm speaking about those times in which the clinician thinks that they have that aha moment, this must be what it is, and then they solely focus on the individual sexual orientation of being lesbian, when really that particular client may not have an issue with being lesbian. They may have had a coming out process that was very supportive. They may have been in their space of identification for many, many years. And the depression could be something totally different. It could be about a lack of employment. It could be about a recent loss of a friend. We don't necessarily know. But if you're just honing in on the identification of that individual, that is an example of attempting to pathologize the individual's orientation as for the reason why they're feeling depressed. That's a snapshot, okay? Now, if we're thinking long-term and we're talking about more process, more of a building of a therapeutic alliance, if we're talking more about the building of rapport, then maybe later the aspects of what it is to be lesbian and how that is received by the world, maybe at some point that may be addressed. But the initial stages of the building of rapport with the individual should be held open, just as open as if the individual identified as heterosexual. Meaning there are many different things that could be going on for this individual, just as somebody who's heterosexual. And if you're going to give that space for the individual to identify as heterosexual and therefore normalize it and not directly go for their sexual orientation identification, then that should be allowed for individuals who identify as LGBTQ plus.
So I thank you for that response and clarification. So I think, or the way I would perceive it is an individual that might be pathologizing that particular client or person they're serving, their gender identity or their sexual orientation. Would you say that more often, or in your experience, or from having worked with clients yourself that you've had, from your experience providing services to them, or just research experience, is that more of a person attempting to be affirming and maybe not fully understanding versus it being them kind of honing like this is a problem, so they're not looking at it as like this is a bad thing, but like I'm trying to be affirming, so I'm focused in and honed in on this, but to the detriment of the person, like you're not helping with my problem.
Yes, and some of us within the profession, we may think that that's the right way to conduct those particular sessions, and again, inadvertently pathologizing while you may feel like you're attempting to affirm and celebrate and connect with that individual. That is solely based on your value system when we're doing things like that. That's solely based on the clinician's value system and their idea around what it means to be LGBTQ plus and their assumptions. And that's what they would be working from more often than not. And those are the things that we have to be mindful of, even within our profession. Most of us, I'd like to believe, are open-hearted, well-intentioned, social justice-driven, equity-focused individuals, and we can inadvertently provide this service.
So let me go ahead.
No, I was just gonna say, by focusing on a particular aspect of an individual, in this case, a sexual orientation, and not allowing for other aspects of the individual to come into that space, because we've already locked in, and we shouldn't already lock in on that. Because what are we saying? If we're not locking in on that for heterosexual individuals, and we're locking in on that for our members of our LGBTQ community, then there's some undertones of possibly thinking that being of LGBTQ identification is abnormal, which it is not. And therefore you're moving in a direction subconsciously where the client may not have an issue.
Great point. So I'm gonna come to a question with implicit bias on it, but I wanted to ask one before you said that, to where the person looking at or feeling that this individual as a member of our LGBTQ community needs to be treated differently. Can some of that again be, we hear maybe information and maybe not always the context for it, of you hear things like LGBTQ youth are at higher risk for suicides, LGBTQ youth are at higher risk for homelessness, LGBTQ youth, I've heard statements that are, I can't remember the exact term for it, but it was basically saying have more justice involvement, to where that one I kind of questioned the context, because I was like, well, if you look at the population of California's justice systems, it tends to be disproportionately persons of color. And maybe there's intersectionalities in there, and some of those individuals are also members of LGBTQ. But I think sometimes it may be like when they're looking at certain rates, or maybe they're looking at national trends and numbers, they don't necessarily always equate. And do you think those things, in an effort to try to inform and be supportive of the community, our LGBT community, people we serve, it maybe gives clinicians, practitioners, maybe a false understanding of what's going on, and that may be part of what causes them to hone in on their sexual identity versus the whole person?
Well, I think
is my question making sense?
If I'm understanding, that's what I'm saying. If I'm understanding you correctly, are you asking more about them and maybe their lack of understanding of how intersectionality works?
Well, now you raise a really good question. Yeah, I guess it's is it because of the information we're provided in an effort to help make us more responsive, sometimes misinforming us, if that makes sense? Right, like I'm getting the info, but without getting the right context for the info. Now I'm like, oh my God, I have to be worried about this particular client more than the other because they're a member of the LGBTQ community. Saying, okay, well, yeah, they're at higher risk for suicide, but that doesn't mean that particular person in front of you is automatically going to be suicidal because they're so. Again, it goes back to your pathologizing, but I guess it's are our providers and practitioners inadvertently, like with the info they're getting without getting the full context, sometimes then led down a path to pathologize.
I believe that there are some practitioners that can fall into those categories, but that's where research and training and immersion is so important. So an individual can not only just have one aspect or understand one aspect of that person, but to understand that within our LGBTQ plus communities, we're all multicultural and all multifaceted. And we hold different and various identifications and roles and positions in our lives. And just as individuals who identify as heterosexual, those identifications and those aspects of power and privilege can change. dynamically, depending on your environment, individuals you're with, situations. And it's important for practitioners, if they are not doing this already, is to really begin to think about Kimberly Crenshaw's coined term, intersectionality. And what she speaks of is that it's not just a person who identifies as a woman. It's not just, it's not just focusing on an individual as them being just a woman or just a lesbian or just of working class or just of a veteran. It's about how all of those identifications intersect, how they connect, how they overlay in the individual's life. And as we as practitioners, if we aren't doing this already, we have to begin to think of individuals, especially our individuals in the LGBTQ community, Black, Indigenous people of color, because there's an aspect of living as LGBTQ. And then there's an aspect of living as an open or out member of the LGBTQ community versus an individual who has not come out for various reasons. Both of them should be respected, right? And both of them can come with consequence, right? Then we talk about the member of the LGBTQ plus community, and if they're a person of color, that's another layer. And if the individual has come out and is a person of color, there's a different experience possibly than a person who's LGBTQ plus person of color who has not come out.
Yes.
Different set of consequences. Then if the individuals we're talking about, if they identify as cisgender women, how does that work? Then what if they identify as transgender female? How does that work? All of these different layers. And then, are they employed? Are they unemployed? Have they had experiences with the police or the legal system? If they have not, are they veterans? Are they not? It's so many different layers that impact the individual. And the layers that we're speaking of are really how society and their perspective of the individual and their impact on the individual, how has that affected the client? And it's really important to be able to take in all of those particular dynamics within the individual's life. The individual is not just a member of the LGBTQ community. These individuals, if we're talking about LGBTQ, BIPOC, Black, Indigenous people of color, and then we're talking about they could identify as members of two communities, right? And then they may identify within identifications around gender expression and the other different identities that I spoke of. And then there are even more. And clinicians have to be open and aware to ask about all those different aspects of the individual to truly contextualize what could be going on for them and not just focus on their LGBTQ plus identification, although it should be acknowledged. And we should ask at some point, how has this impacted their lives? To solely focus on that is an example of pathology, excuse me.
So I guess some of the challenge, well, I don't want to say challenge, maybe a consideration then for that practitioner is kind of walking the line of making sure that they are acknowledging and affirming. But again, if that's not what brings the person in for services, not to hone in on that. So you don't want to go like, well, I'm not going to bring that up at all. Be like, well, that's again the intersectionality. That's part of who they are, and acknowledging, but making sure that, well, is that something that's impacting what brings you here today? And if it's like, no, it has nothing to do that, we're like, okay, yeah, let's move on. But if they say, well, you know what, maybe because some of it is with my mom and my mom has issues with this, like, okay, well, let's now maybe we're not saying that that's the case. It also may be like you're really rude and don't listen to your mom, and that could be the issue. It has nothing to, But you know what?
Right, we don't necessarily know at that point, right?
But you know what? Let's put it all on the table and looking. And I think, and well, let me segue with that question. So those are some of the things that I think we have discussed, and part of your research and also eventually your development of the curriculum is going to be to help hopefully our clinicians in Fresno County, and it won't be limited to just our behavioral health staff, won't be limited just to our system of care. We do want to try to get a lot of different people involved, because there's a lot of different, whether they're in private practice or different agencies that do serve our that may serve our LGBTQ communities, and really having them I don't say understand, but hey, how can we continue to enhance our work and services? So it's some of what you're, without giving away the curriculum and the training, because we want people to be excited and come and participate in that. But is some of the work then that you're intending or envisioning to be to help them understand that and maybe navigate ways of acknowledging and putting that on the table without pathologizing the person they're working with?
Yes, absolutely. And I think one of the, can I speak to just one aspect of what we're going to do a little bit?
Yeah.
Okay. I think that what is going to help us so much, and it's really going to involve our Fresno County community, right? Are the anonymous surveys.
Yes.
I think what is going to be really special about what we're putting together is we want to hear from the community. We want to hear from you, your voice. What helps, what has not helped, what do you think will help? We want to be able to hear from you, so then we can, be able to have these conversations and make those adjustments, so everyone can feel as though they have a right to appropriate health care and mental health care, and they can access it. And I totally believe that this works hand in hand with the culturally responsive plan that you, Dr. White, and Dr. Callahan, and I might
there's a lot of people involved.
Yeah, UTEC.
Yeah, our director, our leadership team, and there's a lot of people that really supported this work.
And it's wonderful. It's absolutely wonderful. And it just is saying right now that you are going to talk the talk and walk the walk. But what we really need, and what is going to really make this really unique and really enriching and helpful and appropriate for our members of our community, is to hear their voice. And we're going to make sure that is definitely a possibility. So we want you to know it's anonymous, and we really want to hear from you. And from there we can move forward with discussions and possible adjustments to be made.
Yeah, if I can add to that, Dr. Williams. So the survey that is being developed, that Dr. Williams is referencing, is there's going to be one for members of our LGBTQ community, and so we're really hoping that those who are from the community, work with the community allies, when we get this information out, we'll help share it and promote it, even if they're not in care, even if they don't need behavioral services or mental services or anything like that.
Yes.
Just because we want to hear, like Dr. Williams said, what works, what does not work, what would be useful. And we're also going to be surveying providers. So we're going to send the information out to our system of care, to our different partners and supporters around the county that operate in this field, whether they're nurses, case managers, therapists, clinicians, things of that sort, because we want to hear from you in terms of what has been your experience, what is maybe your level of comfort or understanding, and where you feel you would benefit from additional training. And then also from some of the larger provider organizations to see how often have they been able to provide services. Is there what's the word I'm looking for? Not lack of, but do we have they had challenges in finding maybe specific LGBTQ trainings around working with Black, Indigenous persons of color? And so all of that work that Dr. Williams is talking about is what she's going to use to then help design the specific curriculum and training for us. So it is Fresno. So this is not going to be based on what LGBTQ community or providers in the Bay Area or San Diego or someplace else. This is going to be your guys' voice as a member of the community, this is what I feel or see or need. As an actual practitioner, say, hey, you know what, this is an area that would really help me do a better job. And so that we really are going to be able to deliver a truly Fresno-centric LGBTQ BIPOC training. So if I can add, or not add, but build on that. So Dr. Williams, can you maybe, again, based on the work you've done, the research, maybe kind of touch on why we would need, again, you touched about a little bit with the intersectionality, but really maybe why we're focusing on not just the intersectionality for the training curriculum you're looking at developing for us, but focusing on, African-American and persons of color more specifically as part of that intersectionality, or maybe why there's a need to understand the dynamics in there to be effective.
Well, there's a need because there's a huge gap, right? There's a huge gap in between individuals who identify as BIPOC. That's the first one. There's still disparity between resources and access. And then when we layer on the another identity that's considered marginalized, LGBTQ, the individuals who identify as BIPOC and LGBTQ are at a greater disparity than individuals who identify as BIPOC. And what we want to do is we want to make sure that, and this is social justice driven, we want to make sure that everyone has an opportunity to access appropriate healthcare and mental health care. And there are, and in this particular instance, our BIPOC LGBTQ plus members, many of them are not being heard. Many of them are not being seen. Many of them may feel as though there aren't any services out there for them. Many of them may not know that there are individuals in the Fresno County behavioral health system who care and who want to make sure that they know that there are services out there if they need them. And what we're doing is we're going to go out into the community. We're going to offer the surveys, as Ahmad said. We're going to go into the professional setting, offer the surveys, and we're going to get this information because we know that if all individuals aren't provided an opportunity for access, then we're still working with social injustice. We're still working with health inequity. And to make sure that we are extending and expanding and reaching out to specific populations who are considered marginalized makes everyone else and the work that we do that much more greater. So this isn't, although we're focusing on our BIPOC LGBTQ plus members within this particular project, this project is for everyone. Everyone's going to be impacted positively by this, whether you identify as heterosexual or LGBTQ plus, various gender expressions and identifications, racial and ethnic backgrounds. This is really for all of us. It's for all of us to learn from each other. We're going to learn from our BIPOC LGBTQ plus community. They're going to learn that we're out here and we're here for them. And hopefully those two interactions or those two messages alone will bring in individuals who may be seeking services. We do understand that our percentage rates are much higher for our BIPOC LGBTQ members, with suicidal ideation, suicide attempt, substance use, high school attrition or dropout rate, all of those
homelessness,
things. Yes, homelessness, all of those things, the percentages are much higher in those particular groups and communities. They deserve better. Absolutely. They deserve better, and they have a right to know and to access various resources that could help them reach and attain the well-being and the lives that they deserve to live. And we want to be a part of that.
So Dr. Williams, do you foresee like the curriculum or the training also touching maybe, will be touching on how maybe the culture or maybe the specific communities within our, when we say our Black, Indigenous persons of color, obviously it's a very broad term, even when we've narrowed it down to that, right? Versus, but of looking at how, in those specific communities and cultures, how those are also some of the roles. Because I think you talked earlier as far as how society has an impact on the client or person who might be of LGBTQ, but then how that might be, I don't say enhanced, but how there may be some additional layers or additional pressures if the person now happens to be a member of the LGBTQ community who's out and identifies as a person of color or as African American or API or something else, and then have that specific their community culture and background may also be something that they're having to navigate and understanding.
Absolutely. Within the surveys, we're going to be talking about that. We're going to ask those types of questions. We're going to ask them about cultural aspects of how their own culture has impacted their identification or their journey, so to speak, through the world. We're going to familiarize ourselves with the various belief systems and value systems within the BIPOC community around what it means to identify as LGBTQ. We're going to ask those members who so choose to anonymously fill out the survey about that impact, and what they would think would help navigate or help another individual navigate through those processes. We're going to ask about religious aspects, religious identification, and how that impacts the individual. So we're definitely going to take a deep dive into the various cultural considerations for each group that we are going to provide the surveys for. We're going to take on the more of the macro system approach around society and its impact. We are going to also ask some similar questions to individuals who are the professionals, the clinicians, those providers. So it's going to be what I hope that comes out of this is we are presented with various narratives and various personal experiences of individuals. As we know, the individuals are experts of their lives, right? We provide a particular service of expertise that we've been trained in, but the individual is still the expert of their life. They're the one walking these shoes every day. So for us to be able to get that narrative from various walks of life and to see how how both of those interplay with society's general ideals or ideology around LGBTQ and what is considered heteronormative, heterosexist, gender binary ways in which we move along from a mainstream perspective. We're going to see what that looks like, and come up with some really innovative interventions and strategies to hopefully, again, send a message to our LGBTQ plus BIPOC community that we're here, we know you're here, we're going to reach out to you. You're more than welcome to come and take on what we have as far as resources and access, and hopefully be a bridge and make and helping or letting the community know that there is access.
Awesome. Yeah, I mean, I think when we, this is a while back, I think, maybe a year and a half ago, well, maybe right at the start of COVID, but it was quite a while ago that I think Dr. White and I had reached out to you and said, hey, we were trying to, first of all, see what was available, what might be out there that in terms of trainings that could just help with being more culturally responsive to LGBTQ persons who were also identified as Black, Indigenous, persons of color, and other marginalized communities. And then knowing that there were, as far as some limitations, and then really ones that would also, what is the word I'm looking for? That would be viable in a place like Fresno, right? So we're looking at 5th largest city in California, but in a county that, if you go 15 minutes in any direction, you're in some of the, ruralest parts of California, right?
Yeah.
So how do we have those those dynamics, and then understanding that when it comes to maybe some of those local assets and resources from those communities, that we may not have that same richness as maybe a Sacramento or, a Los Angeles, to where we have a lot more community organizations that represent specifically our various diverse populations. So there are some, but we don't have that same volume. So, and then understanding that if you have a training that says, oh yeah, and then refer people to, A, B, and C, refer to your local Native American Two-Spirit program that'll assist them, and we go like, we don't have that. So then our concern was, do we get a training that provides some info, but would it really help us in addressing our community needs? And that's where you had really talked about, well, why don't we design one that is specific for Fresno, and let's get input from Fresno. And I think you touched on it of that would not only help us do a better job, but allowing us to let our communities say like, look, we know you're here and we're here for you. And kind of really making it that mutual of, look, we hear you, we see you, we acknowledge you, and also know that we're here for you and we're here to support you. And I think having something that's inclusive, and again, I'm going to use the term Fresno centric, is really going to be innovative, and I think boost and improve our efforts to be more effective in how we support not just our LGBT community, but our LGBTQ BIPOC, and even maybe our BIPOC community, right? Because maybe someone takes a takeaway from that of like, well, I know this was for persons who identify as LGBTQ and BIPOC, but could this other factor be at play as well? And not that you take that one training and use it in another way, but maybe then someone takes that training and say, hey, you know what? I need to learn more about A, B, and C.
Right.
Like, how do I now continue that development self? Like, you know what? I don't want to make a generalization. Let me find out. Let me sign up for training. Let me look at what's available. Let me maybe reach out to a colleague of mine who does that work. Hey, Dr. Williams, how would you, recommend me deal with situation A, B, and C? Or what would you recommend as a training? And so really we can create a more informed, system of care here locally.
Yes. And I'm so glad you said that, because again, we are focusing on our LGBTQ plus BIPOC community, but this is for everybody. Everybody can learn from this. Everybody can provide their perspective, as I was saying before with the surveys. So these are not just relegated to individuals who identify. We are definitely asking for individuals who identify as LGBTQ plus BIPOC to participate in the anonymous survey. At the same time, we don't want to give off the impression that we are excluding other members of other communities, whether professionally or a part of our community. We're just letting everybody know, it's, everybody's going to be able to benefit from learning so much of this information that the members of Fresno County will be providing. I'm excited about it.
And one of the things we hope this training does, other than help us as a system and as a community better support our other community members, which I think, you kind of touched it, like that's kind of the impetus of social justice, is how do we, make, that inclusive and make sure that everyone is able to access, the care and services. For us is hoping that the training is first step for us, and hopefully being now armed with that training, we can have additional discussions and dialogue to look at what's the next step. So what do we need to better serve now our LGBTQ and our LGBTQ BIPOC communities versus making, assumptions like, oh, well, there's a need and we need to do that. Okay, but what does that actually look like? And let's not make assumptions. Let's actually talk to the community, talk to our community members, really get information and make, really informed decisions that'll get the results we want and support our community. So
absolutely, no cookie cutter approaches, right?
Absolutely. Dennis, I'm guessing that you didn't chime in, that you were not hit with any specific questions that we needed to address. But if we have about 5 minutes left, if people have any questions, they obviously can chime in, but we're going to be wrapping this up shortly. What we will do is, because this is live streamed on both YouTube and Facebook, it'll be up. People can go watch it later. And a lot of times we know that's what people do. They get busy, they have things going on, and we'll come back a week later and look at the views and go like, oh, wow, that was pretty popular.
Yeah.
And I think it's Friday, so people are they may not be able to get to it. So we'll be checking in. If people do have questions after they watch this, and you have some specific questions, not about at this point, about what we were talking about with Dr. Williams in terms of intersectionality and pathology and things like that, that ship has sailed, guys. You'll have to wait. You'll have to wait to the training to ask her that. But if you have questions about the survey and just wanting to kind of understand that process, go ahead and still put your questions in the chat. Even if it's a week from now, or you can put it in there, and someone from our team will take a look at it, and we will either try to respond to you, or we may take, if you put some comments or recommendations in there, things that we can take from there, get them to Dr. Williams, and also include in some of our discussion and planning and curriculum development. So again, input, like Dr. Williams said, is really key to this whole process. So in addition to the surveys, if you've got specific questions for us, you can contact us. We'll also put some of this information up on our DBH equity page. So that is part of our department's website, but the easiest way to get it is just going to be typing in dbhequity.com. We'll have this information up there. And when the survey comes live, we're also going to put one of the links on there as well. So people can always just go there. You can share that. It doesn't have to be some ridiculously complicated website you're passing on to people. You can tell a friend or whoever, like, dude, just go to DBH Equity and the survey's on there, and you can just click it and just do it electronically. So take a look at that. Again, I've been excited for this project. We've been working on this for over a year, not the actual development, but just dealing with COVID and just a lot of projects we have on our plates, and then finally being able to work through getting the key development with the contracts and all that stuff done with Dr. Williams. But it's done. It's happening. We have just finished working on some draft survey questions she's reviewing. Once we finalize those are going to even get translated. So it'll allow opportunity for some of our other non-English speaking communities who identify as LGBTQ and or LGBTQ BIPOC communities are also going to be able to participate. And really that we can have a training that hopefully is as inclusive as possible and help us, really address our community needs. And again, I think going back to the way you were defining social justice, Dr. Williams, as far as, in terms of health and really getting people, addressing those disparities and really having some true health equity.
Yes, absolutely.
All right. Well, if we don't have questions in the chat, Dennis,
we have no questions at this time. There was an individual that tuned in and said that this was a great conversation.
Great. Fantastic.
So, folks were tuned in. We will make it available after we're done. So we'll make it available on Facebook, YouTube, and also for those at DBH on the Relias learning platform.
Oh, perfect. Perfect. There you go. Awesome. And then what we can do for two Dennis is maybe even we can put just like a little, I don't know, say like a placeholder even on the DBH equity that says, whatever we want to call it, question and answer, or conversation with Dr. Ebony Williams, and that way they can just click the link and it can take them to the YouTube.
Yeah, we'll do that. That would be perfect.
And that way they get familiar, hopefully, with that page, and they come back and look for the surveys and some of the info we'll have on there related to this training.
Exactly.
All right. Well, Dr. Williams, thank you so much. We are truly grateful for you taking time out to join us, assisting us with this process, and just allowing our system of care and folks in Fresno to get a little familiar with you, because I know people will always have a question, well, who's creating this curriculum? What do they actually know? and hopefully through this conversation, they'll feel pretty confident and like, okay, she knows what she's talking about. This will be legit.
Yes, and thank you so much for inviting me. Thank you again for considering me to be a part of the team. I'm already enjoying working with all of you. And Ahmad, you and I have history of working together in the past. So it's like reuniting with family as far as I'm concerned. So I'm totally looking forward to continuing our work in this project together. The
only thing is hindering us right now is COVID from us going and doing our food tour as soon as a meeting or conversation is done. So we'll have to make up for that when the opportunity arises, because we'll do that. We won't give away all the good food spots on this. They'll have to tune in for a different meeting for that. All right, Dr. Williams, well, thank you so much. You have a great rest of your day. You have a great weekend, and everybody out there, be safe and be on the lookout for the surveys and more work to come.
All right. Thank you so much.
Thank
Have a
you.
All
good
right,
weekend.
guys.
Take care all.
Bye-bye.